Hello, everyone. Good morning, good afternoon, good evening. Because of our global nature, I'm sure we have participants from all time zones. We are really happy to have you all. My name is Farhan Yusuf. I'm a fellow with Results for Development and part of the team that works on AGORA, a global commons for pharmacy and primary care integration. We are so happy to welcome you all to our first global interactive working session. We have some very interesting presentations, and we are hoping to have some good discussions after those. Just a few sort of housekeeping elements. We have our team member who will be sharing the slides. We request everyone to please stay in mute until we come to the discussion section, but please feel free to keep the chat active. We really want to hear your thoughts, ideas, opinions, etc., and questions as we are going through the presentations. To let everyone know, we will be recording this session just so that we are able to document and then share more widely these interesting discussions, but that is by no means to sort of hinder someone from participating. We thoroughly encourage that. Please feel free to introduce yourself in the chat, where you are from, any thoughts, ideas, expectations from the session today. I will We will start off the session by first inviting Rubayat from the Endless Health Network, who have been a great support for this particular initiative. Rubayat, I know you are online. Would you please like to start us off and say hi to the participants? Rubayat, in case you are speaking, we can't hear you. I hope you are not on mute. Okay, maybe he's still setting up, so we can give Rubayat an opportunity. Interesting. He says he can't find the unmute button. That is
Yes, thank
fascinating.
you, Farhan.
Ah,
Uh,
welcome,
yeah,
Rubayat.
I think this is because this is a webinar, the organizers need to invite people to unmute. Um, no, I don't have a lot to add. I'm really looking forward to the presentation. I represent Endless Network, which is a family foundation in the US, and we have been really privileged to support this initiative. And as everybody will hear, this has been some time in the making. We've done some really interesting landscaping work that led to this initiative, and can't wait to hear all about it. Just to kind of tie this to my own personal experience, I happened to run an organization called Geon for about 10 years prior to my role at Endless. And I was working with these pharmacies and drug shops in Bangladesh, tens of thousands of them. And what I noticed while working there was just how misunderstood they are in terms of their contribution to global health. Because in Bangladesh, 70% of primary care interactions happen with these informal providers, and yet they're hardly noticed or prioritized or supported by the public health system. And yet they're just such a incredible resource that's available and already highly sustainable. They have been doing this for decades without any sort of external support. Of course, there's when you don't have support and oversight, there's a lot of gaps that still remain. And I think part of the goal of this initiative and this conversation is how do we plug those gaps and reduce those risks and really think about how we can mainstream and bring this major resource that is right in front of, right under our noses, to the light and to bring them to bear in support of the global health goals, especially at this time of funding crisis that's happening globally. So yeah, really excited to hand the baton over to Farhan and the team to take us through this initiative.
Thank you so much, Rubayat. Hearing you speak reminded me that I should probably declare my interest as well. I'm a pharmacist by training, and so, this initiative and everything that we are going to talk about is very close to my heart. Definitely a believer that, pharmacies have been doing a lot and will continue doing a lot, and we just need to find ways to, bring them closer, I guess, and make them a bigger part of the health system. So, thank you so much for that, Rubayat. Moving on, I will now invite Elizabeth Ohadi, Program Director at Results for Development, who will give us a little bit of an introduction on what Agora is and what we are intending to do with these sessions. Welcome, Elizabeth.
Thank you very much. And if you have any colleagues waiting in the waiting room, I think they may be on the Teams link. And so I just sent out a Zoom link to the Teams link for them to join us here. Thank you you're all very welcome. And thank you again to Rubaiyat and Endless. So today, this is our first global interactive working session. And so we are going to, in addition to hearing from our primary presenter, we are going to share a bit about what is Agora and the initial landscaping report that is really the foundation for this work. And then we'll move into our presentation and have hopefully a very rich discussion about the content of that presentation, but also more broadly. Next slide, please. And next. So we wanted to share what is Agora. So Agora is meant to be a global initiative, a global commons with the objective of primary care integration with pharmacies. That's both for pharmacies as well as informal drug shops. And it's really dedicated to building a community, also the evidence and momentum to really take innovations to scale. So during this presentation today, you'll hear from Cheryl Cashin about the findings of a landscaping report that really looked deeply at the challenges to integration. And what we'd like to do with this initiative is then take the next step. What is needed to overcome those challenges and move this forward? And we are bringing together a community of all the stakeholders within the ecosystem. There are innovators, country governments, implementers, donors, and others working in this space we think all of them share a very valuable perspective on this challenge and what is needed to overcome. So we have a LinkedIn page. This was launched about a week ago, and we want this to be a place where there is ongoing discussion. We'll be posting any news, any events such as this, and we hope you'll all follow along. We also have a website we'll be using to post resources, and we will continue to have sessions such as this one for our Global Interactive Working Series. Next slide, please. So we wanted to share what this series of these sessions will be. So there's no intention for this to be a series of webinars, but really we want to facilitate experience sharing and interactive discussion to identify interventions to overcome barriers to integration, especially emphasizing those that are implementable, scalable, and grounded in reality. We also haven't really fully baked everything about what this global platform will be. And we hope to understand from you where can this platform fit in the space of many who are also working on this issue. And we want to develop a learning agenda to also help us most effectively and strategically build alignment, visibility, momentum around integration. And finally, we'd like to highlight the experiences of innovators, implementers, and countries to seed matchmaking across these groups for the design of regulatory and implementation sandbox models. So after the presentation today, there will be plenty of time, we hope, for rich discussion on across all of these. And we hope that you will participate, and we really welcome your feedback. Next, and I think I'm turning it back over to you, Farhan.
Thank you so much, Elizabeth, for that overview. I think just to emphasize to all the participants, as Elizabeth mentioned, we want this not necessarily to be like a webinar. It's an interactive working session. We really hope to hear from people, their thoughts, ideas. If there's any resources that you want to share, just let's keep the chat as active as possible is what I'm going to say. Now, moving on, as Elizabeth mentioned, we will be having an overview of the findings of a landscaping report that we worked on before the establishment of AGORA as a platform. And to do that, I would like to invite Cheryl Cashin, Managing Director at Results for Development. Welcome, Cheryl.
Thank you so much, Farhan, and greetings to everyone. Good evening, good afternoon, good morning. Thank you for joining us and being part of this conversation. We're just delighted to have everyone here together and really grateful for the opportunity to create this space to make sense of so much of the activity that is going on in the area of bringing private pharmacies and drug shops into the formal PHC system. And before we even work together with Endless to design this space, we wanted to have an understanding of what's happening and what do we know as of today, and what can we add to this enormous amount of innovation and activity. So this landscaping report was an effort to understand what's happening, looking at what's in the literature, what has been published, but also talking to people across countries, what's happening from their perspective in their experience. So we'll share a little bit of a snapshot of these findings to kick off our conversation today, and you can find the full report on the AGORA website. Next slide, please. So the current situation, I'm just going to summarize what the landscaping report found. You all know this better than we do, but just to summarize what we think some of the key points are to inform the way forward. Next slide. So of course, you all know, and Rubaiyat laid this out really poignantly, is that the private pharmacies and drug shops all over the world are the first and most trusted point of care for many, many people in low and middle income countries, and not even only in low and middle income countries all over the world. And that is where people go because they trust these providers in their community. And they go not just for medicines and those, they go for services as well. And these points of care are already providing a lot of services, as we'll talk about, in family planning, maternal and child health, more and more in non-communicable disease management. So this is happening. And the community has a high degree of trust in these providers, and they're really accessible. I think that's so important. It's meeting people where they are in the community. So despite all of this that's actually happening, that people are actually using these providers, they're often not formally integrated into primary healthcare and broader health systems. And we're going to actually have one of our main first discussion points in the conversation today. What do we mean by mainstreaming and integration of these providers? So I think that's something we want to have a common understanding of what we mean by that. And I think our landscaping report will give a few guideposts, but we want to flesh that out together with all of you. And then from there, getting a common understanding of what good looks like. Next slide, please. So the first thing we want to say is in this space, in this, how we're thinking about this group of providers, we want to be inclusive because everyone uses all the providers, from the most informal, unlicensed drug shops that are in communities that don't maybe have training or formal qualifications, but they're there and people are visiting them. And then we have the licensed drug shops that have a bit more formal place in the system, have some training and supervision, but maybe not formally integrated into care pathways and financing. And then, of course, we have accredited pharmacies and chains who have a lot of capacity and are participating in different ways in the mainstream publicly funded health system. So we want to be very inclusive in our definition. And if we're missing anything, please let us know in the chat. Next slide, please. So the landscaping report diagnosed 6 interconnected barriers to integration. I don't think any of this will be news to all of you. You're very well aware of these, but just to be explicit, we found over and over again that are limits and restrictions on the scope of practice for the private pharmacies and drug shops, what they're legally able to do in the system. And that's especially related to the services that they're legally able to provide. We also found that there is limited contracting, and by contracting, we mean that there aren't really formal mechanisms to engage the private pharmacies and drug shops in the public formal system. And so a contract is kind of a catch-all term for a formal way of engaging and accessing services and paying for them. And that's the third barrier, is reimbursement and payment, that there are very limited ways that we can see public funds being able to reach and get to the private pharmacies and drug shops in exchange for services. That's also related to quality assurance. There's very weak regulatory enforcement, and that gets more and more difficult in more rural and remote areas. And so just the capacity to understand what these providers are doing and making sure that there is quality services being provided. Data and reporting is always a challenge, how to get the data about what is happening in these providers and bringing that data into the formal information systems for planning purposes, for reimbursement purposes, again, just knowing what's happening. We just don't have that data coming into the system. And then the supply chains, this is related specifically to the medicines and supplies, that these pharmacies and drug shops don't often have access to the public supply chain. Go ahead, that's fine, Olivia. Next slide, please. So, of course, that is a picture that you're all very familiar with. And this informed the strategic levers that we found in the landscaping report that are being used to innovate to overcome these barriers. And so we wanted to look at these levers from the perspective of innovation, what's happening, what is out there, what are the creative ways that the different stakeholders are overcoming the barriers. But we want in this space to take it to the next level. So how do we go from innovation to scale? And what can we learn about that? And I'll share a little bit about some of our emerging understanding of this from the landscaping report. So we found that there are 6 strategic levers that different stakeholders are using across many countries to overcome the barriers to integration and mainstreaming. And these levers match pretty closely to the barriers themselves. But the first one has to do with aggregation. And I hadn't mentioned that underlying all of the barriers that we found to integrating private pharmacies and drug shops into the formal system, a lot of it comes back to the fragmented nature of these providers. And there are so many of them, and they're operating independently and in parallel. And so it makes it almost impossible to start to engage and overcome some of those obstacles. So one of the first things that we found helps to get on a pathway towards more integration is some way of aggregating providers. And there are different innovations, and we want to hear from all of you, but ways to bring the pharmacies and drug shops together to engage as a group with policymakers or innovators or others. And aggregation can be among the pharmacies themselves. It can be through networks of public providers. There are different ways that we're seeing this aggregation happen, but it's a really important first step in many ways. And then the lever around quality assurance, starting to define minimum standards for the services that different pharmacies and drug shops with different levels of qualification can provide, and making a pathway towards accreditation. And that might be a gradual pathway, but what are the building blocks and steps that can be put in place? And we'll see some examples of that. And then, of course, financing and incentives. That one of the major issues that comes up over and over again in these conversations is how to align incentives and interests. That the pharmacies and drug shops have their business interests and their incentives. The public system might have different objectives. How do we use financing and incentives to align those objectives? And we have a lot of great examples of that, and it's really possible. And I think one of the most exciting areas of progress that we have to look forward to. Supervision and referral, having ways to bring the private pharmacies and drug shops formally into the referral pathway and have been formally part of the service delivery architecture, and then supervising and making sure that they're playing the role and that the handoff happens in the right way when referrals need to happen and what's being done at each part of the service delivery architecture is correct and there are connections across them. The data and reporting systems. We're seeing a lot of innovation on collecting data from the private pharmacies and drug shops and different digital innovations there. How do we get that into the broader national health information system so that it can be used for planning purposes and other purposes? And then underlying all of this, of course, are policy and regulatory levers and reforms to be more formal. And so I think the headline from our landscaping report is that countries are using all of these. We're seeing this, we're seeing some combination of these levers being innovated and used across every country. And where things start to get interesting is when they're using combination. And so using 3 or more of these levers together in a holistic way starts to accelerate progress towards integration. And using them together holistically is what's going to be required to get to scale. And this is what we really want to learn about. Next slide, please. So this slide is just meant to give you a heat map, not to really go into the detail. You can look at the detail in the report. But I just wanted to make 2 points with this slide. So we mapped out the innovations that are happening, across 5 countries where we did a deep dive in those strategic policy levers. And we kind of ranked them by weak, intermediate, or strong, just to get some sense of how deep these innovations are taking root, how deeply they are taking root. And so a couple of points to make here. I think one is that there's a lot of innovation happening across all the levers, across all the countries. That is exciting. We have so much to learn. Next click, please. But what we noticed is that the 2 that are most difficult are the financing and incentives. So bringing the private pharmacies and drug shops into the system in a way that they can receive public funds. Not just donor funds, but public funds. That's the sustainable source of financing. That's really challenging. And the second one where we see less deeply rooted innovation is around embedding these providers into the service delivery architecture in referral pathways with supervision and very, very clear scopes. And we think these are the 2 that really are the most important to understand and overcome to get to scale. Otherwise, we're going to be staying at the level of pockets of innovation. So this is, I think, a really important direction for our learning community. Next slide, please. And just to give you 3 examples of these entry points and levers and how they're working and where it might stall, there's some great experience in Nigeria where the Society for Family Health and Pharmacy Council were working to look at what they're calling patent and proprietary medicine vendors, and looking at their tiers of qualification and giving the right task allocation at each tier with training and supervision for family planning services. And so that's working on this kind of pathway, changing the scope of services, the pathway to accreditation, and worked really well. And this tiering process and being very deliberate about the scope, the training that they need to carry out the tasks that are allowed in their tier. And so this policy is being scaled up. So it's a very exciting example in one of our levers, actually several of the levers, but there's still challenges integrating into the information system and connecting to the financing. So there's more to do to get this fully to scale for full integration. In Kenya, there is the example of Maisha Meds. We look at this as a digital quality assurance and supervision innovation, that there is real-time inventory tracking through this digital application, with remote quality assurance, tracking what the pharmacies are doing, their performance monitoring. And I think more recently, there's even payment coming through this digital app. So it really demonstrates that this obstacle around supervision challenges, it can be overcome with digital innovations on a very large scale, which was very exciting. There's still a gap, though, that this isn't plugged into the sustainable financing from the public insurance system. And so how to bring this really exciting and very large innovation, very large scale innovation, fully into the public system to receive public financing. And then we see, I think, the closest example in our landscaping report to what we would consider full mainstreaming and integration is happening in Indonesia, that the pharmacy chain of Kimia Pharma is formally integrated into the National Health Insurance Program for chronic disease management. So they have a formal task, a formal service delivery mandate to provide chronic disease management, and they get paid for it through the National Health Insurance System. So it's a really good example of having a clear scope of services, having service delivery standards, where they fit into the referral pathway is very clear, and they receive public financing, and their data is integrated into the system. So all of these pieces are in place. The limitation here, it's really just limited to a few pharmacy chains. It's not reaching the full range of these providers, and so we consider that still maybe not fully at scale, but it's really it's a very good example of all the pieces working together. Next slide, please. So just how to use this information in our learning space. Next slide, please, Olivia. What did this spark for us in terms of how we want to bring it into the learning community? I think we saw there's a need to close or to strengthen this evidence to policy loop. And when we say evidence, we mean not just research and published information, but your experience and bringing that experience in as evidence. And how can we collect that and bring that into the policy and practice in other countries who want to advance this agenda. We also saw how important it is to bring in the voices of the local champions. All of this innovation is coming from, most of it is coming from the bottom up. Identifying the need to bring in these providers and figuring out ways to do that, and then connecting it up to national policy. In some cases, it's a more top-down approach, but it's really the local champions who are driving this, and how do we continue to bring them into this conversation? I think this aggregation and fragmentation issue, it's across the board. And so how are we leveraging networks of pharmacies at the local level, country level, at this global level, and bring and aggregate the voices to bring to bear on change? And this really, I think, is important to bring in the innovators. And so much of what's being driven is some innovator ideas and the digital applications that are able to drive some of the overcoming some of the barriers, but just innovative ideas about the role that pharmacies and drug shops can play. We need to make sure that these partnerships are very strong and are very much part of our community. And then this underlying challenge of all of this, how do we find ways to make it worth everyone's while? That the pharmacies and drug shops want to be part of the public system. It's in their interest, it's in their business interest, and that the public system wants them in there because it also serves the public interest. So what can we learn about aligning interests and incentives and really making this work holistically? So that's all I wanted to share to get our conversation going today, to set the stage with what we found in the landscaping report. And I'm looking forward so much to hearing your reflections and experience and building forward from this. Back to you, Farhan.
Thank you so much, Cheryl. And, we can see already in the chat, there are some thoughts around, experiences with aggregation and, why integration would be important. Some very interesting thoughts. We'd love to get to them when we get to the discussion section. Now, as we also, throughout Cheryl's presentation, we've been speaking about aggregation as probably the first strategic lever, the power of networks, etc. And so we thought the best way to start our global interactive working sessions is by inviting a network to sort of speak to us, a network of pharmaceutical professionals, personnel, that is the Africa Pharmaceutical Network, and we thought it would be nice for us to hear their perspectives as a network on why integration is important, what has their experience been, and what do they think about how this particular group, for example, can assist in some of the things. So to take us through an overview of this thought process from the African Pharmaceutical Network, I would like to invite Dr. David Odhiambo, who is the Executive Director of the African Pharmaceutical Network, but he is also a Senior Advocacy and Public Policy Lead for the Federation of Kenya Pharmaceutical Manufacturers as well. So a lot of networking experience here within Dr. David. So, in the interest of time, David, if you can take us through your presentation, please.
Thank you so much, Farhan. Thank you. And thank you everyone for this session from the R4D team, but also for the participants who joined, because there's a lot of work that needs to be done within the community pharmacy space. And there's a lot of work and actual impact that can be made in delivering products to the patients who need them, and actually not only products, but also pharmaceutical services. And that is critical. And when I'm getting into this conversation, I would want to make it clear that at the end of the day, when we look at mainstreaming and integrating pharmacies into the primary healthcare system, it is about offering healthcare services to people who need them. And therefore, the question we should be asking ourselves is, what is the current perception and what is the current view of the role of community pharmacies in ecosystems and the communities where they exist? And therefore, how do we then integrate them to bring a different perspective and a different viewpoint on what role they can play in delivering healthcare services? Because once we define the place of community pharmacy in healthcare service delivery, then the integration conversations become a different ballgame, because then they will be coming in as primary healthcare centers, regardless of the formation and the structure in which they take. And therefore, then in primary healthcare a primary healthcare center, it is integrated within the whole structure of healthcare pyramid as we look at it from level 1 to level 6 in most of the countries within the region, from primary healthcare to the tertiary hospitals. So how do we make that happen? So that is just kind of an idea of how we're looking at this and how we think about it. So for this conversation, I work with African Pharmaceutical Network, as Farhan has said, and just disclaimer, I'm also a pharmacist and very passionate about this work, as Farhan already started, and Farhan is a good friend of mine for the last, I would say, 6-7 years now, but it's still very young people, so don't you judge. Great. So when we get into African Pharmaceutical Network is a Pan-African convener and advisory firm with a clear mission of ensuring that we transform the Africa's life science ecosystem by bringing together stakeholders, one, to share knowledge and learn new trends and new practices that can help us move the industry forward. And the industry is not from a manufacturing side, but the whole life science industry, with the focus on guaranteeing reliability and access to safe, effective, and quality health products and technologies. And that is in the subsequent slide, Olivia. So when you look at that kind of work that we do as African Pharmaceutical Network, the question is, why did this work become important? When we started our journey in 2020 during COVID period, one of the key things that we noted at that point is that you'll have regulators and policymakers in one corner talking about the key intervention they wanted to put in place to get products and services to the people who needed them. Industry developing products and actually supplying them and maintaining the supply chain to the pharmacy level were also having their conversation and their challenges where they were. But none of these people are actually integrating to say, well, these are the problems we're having and these are the problems you're having. How can we create synergies and unlock those possibilities, including all the different players? And therefore, our essence was, let's establish a platform, one, to catalyze this conversation, but also to facilitate partnerships and see learning areas that we can deliver strategic interventions to close those gaps. And generally, we all understand the gaps in healthcare life science industry across the continent. Global health challenges are still coming up, even when we talk about community pharmacy as it is at the moment. We already know they contributed substantially to the burden of antimicrobial resistance, but they are also the greatest safeguards that we have against antimicrobial resistance when we look at controlling access to antimicrobials. So how do we play that game and actually leverage on their capability close on those gaps? Then the segregation, and therefore then our essence was to bring that platform for the African pharmaceutical ecosystem and drive the conversation on where we need to be. So next slide. And I've talked about the mission of what we do and how we do it. I would say mostly guaranteeing reliability and access to safe and effective health products and technologies. And how we do that is through the different work streams that we have. And that is in the next slide, where we talk about our workforce development, which is through the Pharmacy Academy. Then we have business ecosystem support services. We have regulatory support services. And the last piece is the policy shaping and partnerships. So in the Training Institute, we offer professional certification courses across different domains. We have regulatory support services, which mostly links to either professional practice, and that is looking at it from what are the regulatory requirements in actually professional certification to offer certain services in different domains? And also, what is the regulatory scope of service to bring new products into the market, and what is the classification of them? Because even when you're talking about community pharmacies, the professional who is managing the pharmacy will determine the level of product that they are permitted to sell in different markets based on the classification from prescription, pharmacy only, over-the-counter, general use medicines and medical products. So the scope of regulatory affairs, but also registering and bringing new products into the market. In business ecosystem is supporting the business, them to work as businesses sustainability, but also the market insights to support the work. And the last piece is working with governments and regulators to create an enabling policy and regulatory environment to enable the stakeholders to operate in that market to deliver solutions to people who need them. So with that understanding, when I go to the next slide, it's more about where does this community pharmacy partnership come into, and what is our space as African Pharmaceutical Network in the community pharmacy conversation that we are having today. As we started that journey in 2020 with African Pharmaceutical Network, one of the key areas and one conversation that actually the issue on community pharmacy work started in 2017. And it was from a couple of conversation and convenings where we're keen on asking, if you're talking about clinical pharmacy and biopharmacists are already declared, there's a bias towards seeing our role beyond just dispensing medicines. And if our role is beyond dispensing medicines, then we looked at it in clinical community pharmacy practice. And there's an article, probably I'll share it in the link in the group as we continue the conversation. So if pharmacists can offer clinical pharmaceutical services at the community level, how would we position that? And that started the journey for us in community pharmacy and seeing how do we establish a partnership framework and a partnership mechanism that would enable pharmacies to have standardized ways of practicing, a standardized recognition, but also collaborative nexus on what can they do together to contribute to the national health priorities. And at that point, one of the things that was coming to mind was that we normally have community health outreach activities that everybody will do in different places and formations. But after the community outreach activity, how do we ensure continuity of care to the people who attended the community outreach? Maybe they could be linked to the nearby community pharmacy. Maybe they could be linked to the nearby primary health facility. And how do we ensure that it becomes an integrated model? And that is where our journey started. So from that, when it came to 2020, when African Pharmaceutical Network was officially established, we had the frameworks and everything. In the next slide, we talk about, we started by getting to a research component. So the community pharmacy was to be a platform to one, facilitate and convene different community pharmacies to support professionalization of community pharmacy practice. We have standard of practice. So then there's a benchmark on what should practice look like. Integrating them into national health programs, that is what we need to aspire. We aspire to be. It's still not there and still a journey that we need to work in terms of integrating into the public health, national health programs. Championing for policy changes, and those policy changes might be different programmatic area, and some examples I'll be sharing as we go through the slides. How do we integrate them in delivering different health programs? Because if that is adopted, then we're already moving the practice continuum from one end to another, and therefore the integration becomes an easier model. And therefore, our work mostly would be around, so far has been around research, training and capacity building, as I talked about it. And the last piece is the policy advocacy, but also offering technical assistance where we need to. In the examples that I have, the next slide is on. So just continue to the next one. Some of the work we have, and I would say start with the first one in 2020 during the COVID period. At that particular moment, by the virtue that most public health systems were not working as they should have been because of the scale of COVID-19, but also the impact and the risk that was associated, there was limited uptake of healthcare services generally. But at the same time, you realize that economically, people were not having income because most people lost jobs or were disrupted because of COVID and the restrictions that were coming in. They still needed healthcare services, whether they are now choosing not to get them or to get them. And community pharmacies by themselves, by default, they operate as businesses, one. But they're businesses offering social public health services in their local communities where they exist. So our question was, if people are not going to hospitals, where are they going to? And then we started a survey, first of all, to understand the impact of COVID-19 in their ecosystem and how they were offering their services. And in that evaluation, to see where the gaps were, what support they needed to be provided for. That survey was supported by ourselves, Agriculture, which is an arm of the organization, the African Pharmaceutical Network under Agriculture. We have Pharmacy and Poison Board, the regulator in Kenya, MTM and the Pharmaceutical Society of Kenya, and Philips Therapeutics, Philips Pharmaceutical Limited. So in that context, one of the key pain points that they were seeing was the financial impact, because finances were constrained, the sales were not working as much, but you still had to maintain your operations. The risk of that happened is that most of them actually were laying off some of their staff. So that was a real impact that we're having. Reduction in patient numbers, generally, people don't have money, they don't get to seek care as much unless they have the possibility. Yet, the public health system, which was able to provide the services, if pharmacies were integrated, it would have been easier for them to access services if they are covered under the social insurance scheme. So those are key pain points. The psychological impact in terms of just the stress of COVID-19 and dealing with all that were key issues that came up. But then what support did they need? The frontiers they needed support were, one, mainstreaming into national healthcare systems. Because they were like, most times somebody would come in and they need guidance and they need information. Yes, I'll provide it. But the question is, it's a whole day, probably I've sold nothing. But I've canceled as many people as possible, but nobody's compensating me for that service. So then how do we ensure that incentive alignment that Cheryl was talking about comes into place? And the question was, if they were part of the national health system, that would be a different conversation and a different ballgame altogether. Structuring alternative financial instruments to support the operations. I remember that time we had a conversation with one of the group purchasing organizations that was in Kenya at the time, MedSource Group. And the conversation was to extend a line of credit to some of the member pharmacies to ensure they could still sustain their operations, because they were ending up losing some of their staff, not stocking enough, and therefore then chances are the business is going to close. Assume this is a business that has actually been the anchor in that community post-COVID-19. How do people get services during that period or even post it if they get to die off? And therefore that first structuring financial instrument that will enable them to operate at that time was a key piece. And I know MedSource offered some support to it in that particular phase where things were happening, but also capacity building. And capacity building, I would say that partly informed part of the training programs that we offer, and it's part of the program that we're developing. And the question was, we're talking about community pharmacies doing more than just selling products, just being shops, which is the ideal case scenario. But who gives them the training on how to package their offering to be more of a clinical center than a shop selling products? And how do I ensure that I transform my practice? Because in terms of transforming practice, and for those of us, at least if you have understanding of the behavioral change modeling, is also dependent on the premise where you are trading. If my setup of my premise is a shop structure that I'm standing by the counter and selling products, I will keep selling. So how do we transform the layout of the pharmacy, but also after transforming the layout of the pharmacy, equipping the people practicing in those pharmacies to be able to offer the additional services where things need to be? Those are some of the key findings that we're looking at that we came out from that research. That document is available on our website. Whoever is interested, you can have a look at it with a brief version of it. In the next one, when we go to the next one, at the same time, and this was linked to the psychological impact of what we were saying, mental health service need was actually high during that period. So we did another survey, and this was Bright Culture and Planet Wizard Africa, one of our partner organizations, mostly doing digital behavior change communication and related. And that was to assess pharmacy and mental health. And the essence was, what was the role of a pharmacy and community pharmacy, or even pharmacists, in offering mental health services? Perception from the general public. Because if pharmacies were to offer mental health support services, the users, the consumers must be willing and actually must see that they're able to offer that service. Unless there's a need and there's a perception that they can get it from them, then they won't pay for it. But at the same time, do pharmacists believe they have the capability and actually the role to play in delivering those services? Those were the main questions that we're trying to assess, whether there was that need or there wasn't a need. So from that assessment, one, the general public believed pharmacists had a role to play in delivering mental health services. So at 100%, everybody believed that role existed, and even pharmacists themselves noted it. But then beyond acknowledging that there was a need and there was a role for pharmacists, the pharmacists themselves, in terms of assessing capability, they didn't have the capability to offer mental health services. And I remember foundational part of that study that we did and some follow-up conversations, I contributed to the FIP Global Handbook on Mental Health Service Delivery at the Pharmacy. And that handbook is available by the International Pharmaceutical Federation, FIP. how do we position community pharmacies to be able to offer mental health services? What is the trial in terms of scoping across the journey from primary screening and I would say symptom detection, screening, signposting, offering care and therapeutic management where that needs to happen across the whole continuum. That document is available on the FIP website, and I would recommend whoever is interested around it, that is a resource that is available. And it was partly informed by some of the findings that we had from here. Then beyond those research projects, we did some projects, and I think that is the next one. Next slide. Capacity building a piece, and I would say this one was more during 2020, 2021, and we were looking at malaria care. And the essence of it is you ask yourself, one of the most critical diseases, global health diseases that we need to control and we need to manage has been malaria. When you look at Global Fund, it's malaria, TB, HIV/AIDS. But then in our communities, where you'll find the greatest burden of malaria, most touch points for healthcare services were always pharmacies. So that when we started that study, we just did, it was a study that informed a capacity building program, and the training that we did was a 3-part generally training session. And what we noticed was the National Malaria Control Plan for the Kenya government mentioned pharmacy only in 5 places. That is it, the pharmacy department at the Ministry of Health, Pharmacy and Poisons Board, the regulator, but not pharmacy as a service provision point. Yet, as David, growing up in a malaria endemic zone, Western Kenya, which is a hotbed of malaria, I knew I suffered malaria several times, and even now I've supported people in the community, but where I've bought my medicine has not been public health facilities. It has always been pharmacies. Either I bought it for somebody, I bought it for myself, I bought it for my family member. So the question is, if these are the people who are offering services, why is it that the national strategy does not even have visibility on them? And you realize the data reporting does not cater for the private sector. And they were in the private sector. So the national reporting channels were capturing only information that is reported through the national DHIS2 system, which is public health sector system reporting or hospital reporting. So they will never feature in that space. And that became a gap. So based on that understanding, it was more of how do we drive awareness, have conversation, and actually we invited some of the senior leaders within the government who were addressing public health programs. That was the Deputy Director, Public Health Programs at the Ministry of Health. And the positioning was, one, talk about the role of pharmacies and community pharmacies in optimal malaria care, from community engagement and vector control, social mobilization and diagnosis, therapeutic management of malaria. And the lucky thing at that point was the rapid diagnostic test kit had been permitted for use in community pharmacies to diagnose malaria. So the rapid kit is available at the pharmacy, then the artemether-lumefantrine-based medication for malaria is also being dispensed at the pharmacy. That made it easier. So therapeutic management, the last one was the policy imperative for community pharmacy involved in malaria management, more on saying, can we then change the national strategy to integrate community pharmacies as service provision points in management of malaria? So that was the conversation that we drove at that particular moment. It's still a journey, but it hasn't gotten to where we want it to be. So that is one thing that I would say there. In the next slide, another project. This is a project that is currently in place, and I would say this is a project that we're currently leading. I've seen some of our, I would say, partners and actually benefactors for the program. That is in Supply Health Pro Team. Access to family planning services is a critical piece of work that needs to be supported. In the Kenyan ecosystem, the government has already integrated and actually mainstreamed pharmacies as service provision point for family planning services, not only the sole contraceptive, like the sole oral provisions and everything. Now, in some programs, actually, the government provides community pharmacies, provided they have been trained, that is pharmacists and pharmaceutical technologists, to offer contraceptive services and family planning methods to be able to either get the supplies previously, some cases from primary public health facilities and offer them at the pharmacy, or now they can offer them through the private channel, still not reimbursable by the government through the social health insurance scheme though. So one of the key things that we're looking at in this program, there are pharmacies that have already been trained, which means they can offer contraceptive services, especially the injectable, which is unique in its own formation, and there's a scale associated with that. But then on the other end is what are the key impediments for the general public to get contraceptive services, especially the injectables, knowing that the pharmacists have already been trained and they're actually able to offer them? Because if they have trained, they are competent, they have the facilities at their pharmacies, including consulting rooms and consultation areas where they can administer the injections, then they should be able to get clients and they should be able to serve the public. So how do we get the public to actually trust them, to acknowledge? And you remember in the starting conversation, the past statement that I talked about is, if the public does not perceive that this is a healthcare service provision center, however much you equip them with everything, they will never come. But if they acknowledge and they see the value, and that is where I love the fact that in that particular project, we talked about the mental health, the public actually believed in pharmacists' ability to offer mental health services than the pharmacists themselves believed in their ability to offer it. And even their competency, the public believed they are more competent than they themselves felt they were. So one, build capability in them to be able to offer services. On the other end, engage with the general public to acknowledge that there's a role they're playing and there's a suitability in their positioning to offer that services. In that project, it's still we're driving uptake and actually seeing the drivers and enablers, and then hoping that through that campaign and through that engagement, we're able to get more members of the public seeking contraceptive services from community pharmacies, including the injectables. And if they're able to do that, that becomes a win in positioning community pharmacies as service provision points. But beyond just positioning as service provision points, we're going to close out on the gap that we're having in access to contraceptives. And the impediment that we have with this is we have different options by the virtue that people find it more convenient to get services from pharmacies. They will go for I would say the emergency contraceptive pills and avoiding the long-term method that would be available for them. And if we can make them believe that the long-term methods are available, it would make it easier. So we'll reduce the number of unwanted pregnancies that we're getting. We'll reduce the complications that are associated with some of the short-term methods. And therefore, we make it better for us to have equitability in access to contraceptive services where we need them to be. This is a project that we are currently working on, and we're hoping that by similar time, probably by end of the year, we'll have more concrete information and also a guide on where things can move and how we can make them better in terms of integration into public healthcare systems. So that is just making it clear there. In the next one, next slide. So with that experience, when we ask ourselves, what is the future outlook? And when you talk about the future outlook, next slide. We talk about the future outlook of integrating community pharmacies in primary healthcare services. The part is community pharmacies are already integral in our communities, and we are using them. Even in my own case, I do use them. The question is, why is it that our governments and our communities have not mainstreamed and actually adopted them as service provision points to be part of the national healthcare architecture? That is a question we need to ask ourselves. And once we understand that, we're able to address it. And one of the key pieces that we look at is that if we have the barriers that actually impede people accessing them, but also make policymakers understand the value, it would be a different ballgame. First is professionalize it. And I would say in Kenya, with the developed draft guidelines on good pharmacy practice, which is defining the kind of services that should be offered at community pharmacies, we're expecting that it will set a benchmark. And if the benchmark is set, they're now going to be integrated, and that would give us an opportunity that they'll be reimbursed. Because the critical barrier that we've had is one, concern being out-of-pocket payments. If somebody must pay for every single medicine that they're getting, and it's actually this one has a two-edged sword in its approach, in the sense that the government is pushing for public procurement of social health insurance scheme, which people should contribute to access healthcare services. But if my point of care is not part of the empaneled service providers, what incentive do I have to contribute to the social insurance scheme? I'll just buy it from the private pharmacies. So then the government is not getting the coverage that they aim for. But if that was structured, and therefore then there's a positive incentive to say, if I'm unwell, I'll go to the nearby pharmacy and get my products and my healthcare services, then I want to contribute to the scheme. That would help the government in terms of getting higher coverage, but beyond the higher coverage, also getting more people to access services where they need the services. Confidentiality, and that is where I talked about what is the layout of the premise. If people don't trust the premise is convenient for healthcare service delivery, that becomes a point. And therefore, conversation is how do we change the layout of the premise to have additional facilities to enable that access as it should be. Then we have commercial incentive limiting the extent of professional pharmaceutical service provision. You come to my pharmacy late in the evening, I have a line of like 5 to 10 people waiting to be served. You might need additional counseling and additional consultations, which would take me 30 minutes. Do I want to keep the other people for 30 minutes or so? Or do I want to sell for them because that is where I'm paying my bills from? That commercial incentive will play a different game. So how do we manage that? And then the time constraints. It's late in the evening, everybody's here waiting for me to serve them. I'm only one person managing the pharmacy, and I'm managing them based on the finances that I make. So I just need to get the line moving. So you're moving the queue, but not offering a service, which ultimately then waters down the quality of services that are being offered, and it becomes a pain point. So that is what we look at in terms of the barriers. But we have to move it to the next level. And how do we look at that? I look at case of what I see. So in my experiences from the UK, pharmacies are part of the national health system in the sense that when I was unwell, I reached out to my GP through the NHS. The GP had a teleconsult with me, but then sent my prescription directly to the pharmacy. And when that was sent to the pharmacy, all I needed to do is walk to the pharmacy and get my medications. It is part of the national health insurance system, which means I'm not going to pay extra unless I'm co-paying for whatever it is. At this point, I didn't have to co-pay. So then it parts of the healthcare ecosystem. It also, in a way, helps reduce the aspect of every hospital must have their own pharmacy. So then they're part of that integrated ecosystem. The pharmacy first model of community pharmacy practice, I think this one came mostly during the COVID period with common cold, the minor infections and everything. And the positioning was it started from Ireland, then to mainstream UK. And the conversation was, let us have people with minor complication that can be managed at the point of care at the pharmacy level, be managed at that level. And they are actually part of the NHS system. So they're already part of NHS. These services are now considered so they can prescribe. And when you look at developments in the UK, there's prescriber pharmacies, and there's actually training to be a prescriber pharmacy to be accredited as a prescriber for whatever condition that you're managing in your line of specialization. So ultimately then, if you are setting up your pharmacy, you can be a prescriber pharmacy in the specialty area that you're operating in. And I have a colleague of mine and a friend who is working there. He's now working as a prescriber in his own domain of practice with focus on NCDs, I would say that. So in that context is an advanced practice where you are now getting to the level of qualification and specializations to manage particular domains of work that you're into. Opportunities for collaboration, I think there's work for us to design different models, and those different models should address the key barriers and the key hurdle points that we see. One is the premise layout. Is it a structure, a format, a layout that will be perceived to be a service provision site, a primary center, or is it going to be seen as a shop still? Perception matters. Two, the premise without the competent, qualified professional with the right predisposition, attitude, aptitude, and skills to offer services as expected cannot transform the practice. So that capacity building for the professional to be able to offer the services is going to be a key imperative and a key enabler for us. The third piece is generating evidence to inform and transform policy positioning. Unless we integrate them into different programmatic areas to demonstrate that evidence, they will never be integrated into national health systems. And actually, you'll see a country where the strategy does not talk about the role of the community pharmacy. There's no way the financial will consider it. There's no way the private insurers will consider them, unless they're looking at it as a way to manage their costs or as a way to increase their revenues. And therefore, we need to think beyond revenues and beyond costs to ask ourselves, what are we doing to deliver services to the people who need them? And they need them at the point that is closest to them. And that point is a community pharmacy in their neighborhood. Thank you.
Thank you so much, David. I think, this was such a rich conversation, right? Like the presentation that you've done has presented so many, like different points or so many different pathways that we can go down. But I think the good thing for us is that many of the things that you've spoken about very much again align with some of the levers that we've spoken about, some of the barriers that have been identified in the report. I think, I like a lot of the things that you mentioned as far as like policy is concerned, the fact that we need to include pharmacies in like training, and we need to figure out how do we train them to do more, right? Like not just sort of put an expectation on them, but how do we capacitate them to do that? How do we recognize pharmacies? And, I really liked when you said perception matters. And I think that's a big sort of, it's a small statement, but it carries a lot within it, in that we really need to work towards changing that perception, perception that these are just private sector outlets, they are just out there for money, perception that they don't necessarily know. I know, coming from Tanzania, for example, many a times we've had conversations where, there's also like health professionals feeling like their roles maybe are being taken over. And so, you will hear medical doctors saying that we are turning pharmacies and drug shops into mini hospitals, right? And so there's also that perception that we need to sort of counter, think about. I think, what you spoke about also professionalizing pharmacy and creating like specific services that will be provided there, and then using that conversation about coverage, I think was very interesting for me, because, again, we know many countries are going down this pathway of like universal health insurance or health insurance. And one of the things that I guess they need to realize, as you have mentioned, is that if they don't bring in pharmacies and drug shops, then coverage might be affected, because people will not see real value in subscribing into some of those financial schemes, right? So much. I know I was only capturing some of the things, but there's so much that you've said that I think we'll have a very good time as a team synthesizing some of the things you've mentioned post the conversation today. However, as we had mentioned, we really want people to discuss. So before I sort of ask any questions, which I have plenty, I would like to give an opportunity to other people from the participants. Does anyone want to ask a question to David or Cheryl? For that matter, from her, we are now in that discussion portion of our session today. Anyone who wants to voice, what they have been typing, or just share any thoughts, if you can just either unmute and speak or just raise your hand. Maybe we have a shy crowd, or we need to get this started. From our team, Cheryl, Elizabeth, Rubaiyat, anyone from the team want to maybe respond to, especially like David's presentation and how it has resonated with some of the things that we've heard? Yes, I heard someone speak.
I got my hand up. Can I come in?
Yes, Joseph. Sorry, I hadn't seen your hand. Yes, please. Welcome.
Okay. Thank you ever so much for this presentation. I'm Joseph Kaiwood, like I indicated, originally from Liberia, but I'm presently in the United States. And the issues you mentioned, I see more of it happening. And I'm making a trip to Liberia because I go to pharmacy and people go and tell me, and I've seen for myself, none of these services like counseling and giving basic information. I'm mentioning community pharmacies. These basic informations are not provided to customers or patients that come in. Now, and to get the pharmacies to accept that they have to do this, the shop owners are saying, pharmacy owners are saying, we cannot keep a pharmacist here throughout to provide this counseling. So they had their own barriers. And what I thought of was to say, okay, organize a workshop for that would assist me in going into the culture. So there's a sense of culture that we are protecting ours. I mean, the shop owners, the business owners, on the other hand, the professional pharmacists, and the government. So these are several layers that I'm going to face. I'm sure you might have had this in your country. So I'm thinking first, start with the students, talk to them on a culture of accountability, and then we develop a strategy from there to see how we can meet several sectors in the Liberian community. That is the Ministry of Health, the community pharmacy owners, and the professionals themselves who just used to thinking, hey, we all graduate, we have to work for government, we have to work in a hospital, and they are now looking at going into the community as a very essential part of this practice. What would be your advice on going into this, or what topics you think would be very important in helping me go into these cultures to have people accept this as a norm that we have to provide service for the people?
Okay, thank you so much for that, Joseph. I think what we'll do is maybe take a few questions and thoughts from people before we allow. I think, David, this is something that perhaps you can take a stab at answering. I see Felicia, your hand is also up. Felicia, if you're speaking, we can't hear you.
Sorry, Farhan. So mine is more of a comment, and thank you for the presenters for the great overview. Just to add on the critical barriers that Dr. David has highlighted in terms of what might be some of the factors that are hindering community pharmacies to be used for provision of extended services. And from the experience that we have as in Supply Health working with private community pharmacies, critical to the second barrier he had highlighted around the pharmacy setup structure with limited room, especially for confidential consultations. So what we've seen within the projects that we are implementing is we've worked with the pharmacies to set up a safe space, a space within their premises, just to ensure that even as they are offering for startup contraception services, that the women feel safe and the confidence that they are not just being served over the counter. So this reality is true, and we've seen it transform these pharmacies from just being viewed as drug shops to now transforming into opportunities where more clients are asking for more services that they do not primarily seek for within the pharmacy channel. And it has also seen these pharmacies that have set up this structure be considered for a lot of opportunities, especially when programs like immunization and bit of HIV testing and treatment bit. So it just to agree with that barrier, if at scale, that could be a function that is maybe even instituted more by the regulator, could definitely transform how pharmacies are viewed as just dispensing points, but points that offer quality services. Thank you. Over.
Thank you so much, Felicia. Because I don't see any other hand, I think before I pass it on to David, just looking at some of the chats that we have and maybe giving a chance people to elaborate on some of the points that they have mentioned. Yasmin, I know you mentioned about the experience, and again, building off of what Felicia mentioned, the great work that Supply is doing in Kenya. I know you mentioned that, there is some level of like influence and power within associations, but there are challenges that you sort of mentioned. If you can just elaborate a little bit on that, I think that will also provide context on some of these network-based challenges.
Yeah, hi everyone. Can you hear me, Farhan?
Yes.
Okay. And thank you for that. And thank you to all the presenters and also to this group. It's going to be really exciting. I really like the questions you're raising around mainstreaming and how we come together around some of these definitions. But to talk about our experience with the associations, I think we have been working with both sets of associations that govern sort of pharmacies in Kenya for the last probably 3 years, and that's the pharmaceutical. There's PSK, which is the Pharmaceutical Society of Kenya, and KPA, which is the Kenya Pharmaceutical Association, and that governs the pharmaceutical technologists. And I think we I think Kenya is changing its regulation, and we might move towards a pharmacy council at some point. The legislation is still in Parliament; it hasn't been passed yet. But I think the idea, and if that were to happen, I think the practice would be governed by the council, and there would be changes in some of that. But as they are currently structured, one of our initial goals was to really strengthen the networking, unification, and organization, the capacity of these associations, so they could be the avenue for strengthening and, in some ways, catalyzing the mainstreaming of pharmacies. It has been quite challenging in some ways because the associations are, of course, significantly underfunded. And the way they have sort of evolved and survived is to form a very strong political base. And so when some of these legislations are, happening, this and other things that affect their regulation or affect the way they function, they do have powerful members who are able to represent their voices in, at the political level and at the technical level. But in terms and the membership, that there's a theoretical membership and then there's the paid membership. And I think one of the things we have struggled with is because we actually advocated with some of our donors to put funding to build their capacity as institutions. And it has been very difficult because with the way these associations elect leaders, to a certain extent, it is you can make a lot of progress around understanding what the strategic plan can be, how we can brainstorm with them to become a little bit more financially sustainable. And then you have an election that completely changes the leadership in this institution. And, that leader might have a completely different view. So I think if we are able, I would put this to all of us perhaps as a challenge to think about. There is a lot of power, potential power in that network. And I think if we're able to understand the value that the networks themselves can offer their members, that's something we've struggled with. We hope that would be easier, but so far it hasn't been. One of the ideas that we're exploring is through our work of expanding family planning in pharmacies, we have helped to move the government from a 5-day in-person training to a hybrid model where it's really, it's self-administered online and through sort of, variety of digital tools. And then there's only a practicum component associated with the injection that can happen locally on site in connection with, for example, a local primary healthcare facility. So one of the areas we're looking is, can that course be administered and owned by the Pharmacy Association, who can offer it to their members at a fee? So there's different ways. I mean, that alone is not going to generate enough revenue for them. But I think a challenge for all of us could be, it's like a vicious cycle. The members don't see value, so they don't pay the membership dues. Because the membership dues are not paid, the association lacks that ability to be more organized and to be more influential. And also because they're so political, I think they're not set up very well to offer the kind of structured value. So we looked at so many, we tried to find examples of this in other countries to say, is there a model that we could replicate that's working in some of our countries? And we were unable, perhaps we didn't look well enough, but we were unable to find those working models. So I would say that could be an opportunity for this group to think through as well, because they could play a much more important role than they are currently. And it could also complement what we are trying to do as we think about mainstreaming some of these policies. Sorry, that was such a long explanation, but I hope that was helpful.
No, Yasmin, I think, what you have actually done is you have added to our learning agenda as AGORA. One of the things I believe that was mentioned previously is that, we are really looking forward to like building the learning agenda for this particular community. And some of the things you've mentioned about around what would it take to have like a successful, influential, powerful association, right? What do we need to think about in terms of sustainability, incentives for members, etc.? There's a lot there, but I think it's a great learning question. I think I'll give time for David to respond to, I know, Joseph's question about like advice in terms of like how some of those things can be done in Liberia based on your experience. And again, David, if you have anything to respond to some of the things that Yasmin has mentioned. David, if you are speaking, you are on mute.
Can you hear me now? Hello?
Yes, yes.
Okay, thank you. Sorry, I got distracted. I got a call that broke my internet. So how can such a thing be implemented in Liberia? I won't say that I would give you an exact answer of how it could be, but this is context specific and is also guided by how are things working in your country? What is the current dynamics as it is? From my limited understanding of Liberia, I know we have the general pharmacies and everything, not in the public ecosystem per se. So therefore, the conversation has to start from how do you position community pharmacies, first of all, to be recognized as care centers for the general public, and then the different public health programs that are being run within Liberia, how do you mainstream them into them? So it is more context specific, but I would say the starting point is with the pharmacies. That would be my earliest starting point. Then conversations on the public and choosing a particular program that should start off. And I like the question that Jasmine mentioned here is the fact that how we don't have models or best practices, but you have patchwork of models of what has worked or what is working in piecemeal. Can we then take, for example, and I would give the case of Kenya and the work that we're doing on family planning products and say, can we map that journey from end to end? Then once we've mapped it from end to end, we ask ourselves, what levers do we need at each of the different touch points? And how do we attack them for that particular segment and particular programmatic pillar? Because unfortunately, our healthcare system still works in programmatic pillars as it is. But if we are able to tackle one programmatic pillar to demonstrate it, we'll be in a different level and in a different uptake in terms of where things to be. Then the other piece that I would say would really be critical. Currently, we have a situation where each of the different stakeholders are doing their piecemeal of work in a particular segment, but not much of synergistically coordinated. So you'll find we are doing demand generation and service delivery for family planning services in a pharmacy segment, and somebody is doing a similar program in a particular pocket. But then all that evidence is not aggregated towards a common mission. If we could have more collaboration within the ecosystem, it helps, one, create a consolidated and coherent case of what the best case should be. But at the same time, it also extends to ensure that the different verticals that we need for the whole of the community pharmacy programming around a particular disease area is integrated. And that I would say is still a gap. Somebody would start by training, but the training does not lead to service delivery. Or somebody is talking about the premise transformation, but as a pharmacist, if I'm not getting business coming in and there's no commercial return, why would I go to a larger premise? Why would I invest in additional infrastructure and additional rooms if I'm not going to see the commercial value of that investment? And these are honest considerations that we need to look at and ask ourselves, okay, if that is the thinking and that is the mindset, how do we look at it from a commercial incentive as an entrepreneur, but also look at it as a public health imperative to ensure that we are making transformation in both sides? Yeah.
Thank you, David. In the interest of time, I see only one hand, so I think I'll allow that. James, if you have a question, and then we'll just wrap things up with David. Yeah, James, you want to say something?
Yeah, thank you so much. It's actually a comment or an addition, and I work with in supply, and I'm in line with what Felicia and Yasmin have said. And I think as David was presenting, I was actually reflecting on the journey that we have taken in onboarding currently the 600 pharmacies that we are networking with. And after we had the policy and regulatory framework done to support the pharmacy training and offering of services. We have seen very high interest in terms of those who are interested in training. But most importantly, amid so many learnings that we have picked, one of them of the learning is as we strategize to lay our own primary healthcare services in the pharmacy, in the community pharmacy channel, most of the partners are coming into that space with the public sector mindset, the public sector faced approaches and strategies, forgetting the value and motivation from the other side is business in addition to facilitating access of services to the people. So my comment would be, as we move forward, we need to make sure that we are co-creating the approaches and solutions with the community pharmacy providers. And also, we are also, in addition to research, and also we are also linking them to the public health sector stakeholders forums, and we make sure that the public health sector forum normalizes community pharmacy outlets as one of the service delivery centers, so that that can continue building trust the wider clients. Over.
Thank you so much, James, for that comment. So, David, as we wrap up, I think one of the things that sort of as parting shot that I think we would love to hear from you is, with regards to the Africa Pharmaceutical Network, right? Like, what is your experience when it comes to aggregating, these pharmaceutical professionals together? Are there any specific challenges or successes that you want to sort of mention? And I think also, because we heard from Yasmin, there are challenges around sustainability. How is it that the APN, the African Pharmaceutical Network, how is it sort of thinking about sustainability, and what measures have you put in place to ensure that? I think that would be a good place for us to sort of end the session today. We'll just do a bit of closing remarks after your quick response. Thank you.
No, thank you, Farhan. I think that is an interesting question. I was about to just tell you I'll be sending you an invoice for this to sustain my programs and the work that we're doing. But yes, I think one of the key things around sustainability for us, it's still a struggle, yes. But one thing that we do, especially for the work that we continue doing, is seeing for the different stakeholders that we engage, for example, different community pharmacies, are we designing a business model behind the programmatic support and the work that we're offering to them so that it is self-sustaining? If we are able to hack that in some of the programs, I would say for the work that we do, then it makes it be continuous. And one thing that we've noted is that if we do it, it's kind of, they own the process, but then we guide the process with them. If it has a commercial incentive that actually they see the return on it by themselves, then they're able to take it up and actually move it forward in the subsequent phases. And even for the work, I'm sure we'll be able to share some of the feedback and some of the results that we are trying to generate for the project that we're doing within supply. And there's some different models and even some of the initial preliminary conversation with the pharmacies. They're like, if we get this kind of hands-on support to drive their own community engagement and community integration in a way that their service delivery is sustainable in terms of generating returns, then they would be more keen to continue that work. And if they're continuing it, then it means we will have the evidence and the reporting of what their contribution is. If that happens, the alternative revenue streams for them would happen. But in our case, we say, we do it. Sometimes there's no financial return to give it sustainability in the immediate moment, but we stay focused and grounded on the hope that there's a change that we're making in the ecosystem. There are people who are seeing that catalytic action driving us to the next level, and definitely it's going to open up possibilities as we move. But I would say there's need to look at business models anchored within the different interventions and the different programs. For now, yeah.
Okay. Thank you so much for that, David. I mean, one thing that you haven't mentioned, but I can mention it because I've been a beneficiary, is that David's academy, the training academy that they do, is also a very great sort of, I have benefited from some of the trainings that David and the African Pharmaceutical Network provide, and that is at a fee, so I had to pay for that training. But I value, and now there's an alumni network, etc., that we are benefiting from. So there's also that, I guess, element that can be thought of in terms of sustainability. It's definitely providing value to members. And so, thank you so much, David, for spending time with us today and for sharing. And thank you to all the participants. I'll just hand it over to Olivia, our team member, to sort of close us off for today with some quick pointers at the end. Thank you so much.
Yeah, thank you so much, Farhan, and thank you to David and the African Pharmaceutical Network for joining us today. Thank you all for attending. This has been a great discussion. Just briefly, we would like to mention that we would love to continue this conversation with everyone on our LinkedIn. We look forward to interacting with you there and continuing this enrichment on questions we all have and how we can build this community. We are looking forward to interacting with other stakeholders as well as any suggestions you might have on learnings that you would like to, um, you know, get through this network and through this community and how we can lean on each other. We will share the presentation slides as well as this recording, as well as our website where we will be sharing resources and posting other things for everyone's use. So thank you again for being here. Like I said, we'd love to continue this discussion on LinkedIn and interacting with each other and building this community. Thank you to Rubaiyat from Endless Network for joining us today as well and supporting this community.